It's my privilege to share with you the result of our New Hope Phase 2b study. As we said, these results were presented during a late-breaking trial session at the last American Heart Association convention in Chicago in November. And I would like first to thank, on behalf of Quantum Genomics, Dr. Ferdinand, because Dr. Ferdinand has been on board for New Hope from the beginning to help us to have the idea, to design the study, and he has been very close to us during all the course of the trial. So thank you very much, kids. We have enrolled in the New Hope study a patient with primary, so it's essential hypertension. All the patients enrolled in the trial were overweight or obese, with a body mass index above 25. And our target was to enroll at least 50% of patients of self-identified minorities, blacks or Hispanic. We have excluded a patient with poor renal function. We also excluded patients with type 1 diabetes or uncontrolled type 2 diabetes, and also patients treated with short-acting insulin or sodium glucose cotransporter 2 inhibitors, because this drug has been shown to have an effect on blood pressure. Now, after Dr. Ferdinand's presentation, you are quite familiar with the design of the New Hope trial. The New Hope trial was conducted in the US only. All the patients, once enrolled, entered a running washout period without any antihypertensive treatment for 2 weeks, and received thereafter firibastat in monotherapy, 250 milligrams BID for 2 weeks. If after these 2 weeks blood pressure is controlled, that is below 140/90, the patient remains at the same dose until the end of the trial. Otherwise, the dose is increased up to the target dose of 500 milligrams BID, which is the standard dose, until the end of the trial. For safety reasons, if after 1 month's treatment, systolic blood pressure remains above 160, the investigator may combine with hydrochlorothiazide, a diuretic, 25 milligrams once a day. So at the end of the trial, we have 3 different groups of dose, but I really want to draw your attention that these groups are not to be compared, because these are not randomized groups. Patients were selected depending on their initial response to the treatment. This is an important point. The primary endpoint of the study was changed from baseline after 8 weeks treatment in automated office blood pressure. And Dr. Ferdinand just explained what was automated blood pressure. Of course, as secondary endpoint, we also have diastolic blood pressure, percentage of controlled patient, and ambulatory blood pressure. The secondary endpoint results are not yet available. 816 patients were screened, and finally 256 patients were enrolled. The reason why not all the screened patients were enrolled was because of the target blood pressure we wanted to have. 254 patients received at least 1 dose of treatment, and are based on the intent to treat population. The primary analysis has been done on the intent to treat population. 14% of the patients withdrew from the study, and this is a standard rate of withdrawal. So finally, 218 subjects completed the study on treatment, and this is the per protocol population. I won't show you the per protocol result, but I can say that they are very similar, obviously always a little bit better as compared to the intent to treat population. In terms of the patient breakdowns between the 3 groups, 14% of the patients receive monotherapy with firibastat at the low dose, 250 milligrams BID. It means that 14% of the patients had their blood pressure controlled with a monotherapy with 250 milligram BID until the end of the trial. 70% of the patients received firibastat as a monotherapy during the trial, 500 milligram BID. So overall, nearly 85% of the patients receive the product as a monotherapy. And if we remember what is now recommended into the guidelines, both ESC European guidelines and American guidelines recommend to start the treatment for hypertension with a B therapy. So here, only 85% of patients receive a monotherapy. 15% of the patients receive a combination with firibastat and hydrochlorothiazide. You have also already seen the baseline characteristic of the population. As we said, we really wanted to target a difficult to treat high-risk population, and this is what we finally got. Nearly above 50% of minorities patients, including 38% of black patients, heavy patients, with an average body mass index of 33, and of course 100% of the patients were overweight because this was the entry criteria, but finally 65% of patients were not only overweight but obese. 27.9% of patients with type 2 diabetes and a normal renal function. The baseline blood pressure was quite high. As you can see, systolic automated office blood pressure was around 140 and 54. This is important because we have shown in our previous phase 2A study, and if some of you were here last year when we presented the result, you may remember that the higher was the initial blood pressure, the larger was the effect of firibastat. So this is important here, that we have patient with a high baseline systolic blood pressure. Patient may be enrolled as naive patients, so patient newly diagnosed without having been treated yet, or patient already treated. And as you can see here, 22% of the patients were naive, and 78% of the patients have received an antihypertensive drugs but stopped the treatment for 2 weeks prior to start the firibastat treatment. So what I wanted to show here on this slide was the difference between resistant hypertension and the population of New Hope. Of course, we did not select in the New Hope study resistant hypertensive patient defined by patient uncontrolled despite being treated with 3 classes of treatment, including a diuretic. But from an epidemiologic, this was not an entry criteria, but from an epidemiologic point of view, we are very close to the population of resistant hypertension. Obesity increased the risk of resistant hypertension by 5-fold, and we had 63% of obese patients in the New Hope. The blood pressure control is less in black people, and we had 38% of self-identified black patients in the New Hope trial. Resistant hypertension is more common in women. We included 44% of women in the trial, which is quite unusual because it's really difficult to enroll women in clinical trials. This is only because they are the only ones that read the informed consent usually. That's true. That's true for men also when their wife reads the informed consent. The baseline systolic blood pressure was quite high, on average 154, and it is known that the higher the initial blood pressure, the more likely the patient is to be resistant. And we have also quite elderly patients, and the prevalence of resistant hypertension is higher in elderly. So these are the results on the primary endpoint of systolic automated blood pressure. As you can see on the curve, blood pressure decreased during the trial, and finally, after 8 weeks treatment, systolic blood pressure decreased by 9.7 millimeters, which was highly significant with a p-value of less than 0.0001. Just to remind that when we powered the study, the assumption was that we wanted to show a minimum difference of 7 millimeters from baseline, because 7 millimeters had been perceived and thought to be clinically relevant in this high-risk, difficult to treat population. And finally, we achieved 9.7. Similarly, a decrease in diastolic blood pressure. As usual, it's always a little bit less, 4.3 millimeters, but still highly significant. We conducted a multivariate analysis on the primary endpoint, including baseline blood pressure, gender, body mass index, and ethnicity, and the only predictive factors in the multivariate analysis was the baseline systolic blood pressure. Once again, and similarly to what we found in the previous trial, the higher was the initial blood pressure, the larger was the effect. We also conducted different pre-planned subgroup analysis, and I don't want to describe all the subgroup analysis, but to summarize, there was no difference in efficacy of firebastat across the different subgroups, whatever the age, whatever the gender, whatever the body mass index. And I just wanted to highlight two specific subgroups of interest, and especially in the perspective of resistant hypertension. The first one was to compare the result in Black and non-Black patients. Why? Because first of all, Black patients are more likely to suffer from resistant hypertension, and as mentioned by Dr. Ferdinand, are less responsive to ACE inhibitors or ARBs. And as you can see here, the firebastat was at least as effective in Black and non-Black, with a decrease in blood pressure of minus 10.5 in Black versus 9.1 in non-Black. The difference is not significant. The p-value for interaction is not significant, saying that the efficacy is similar. And these results are not because of a different baseline characteristic, and especially the baseline systolic blood pressure was exactly the same in Black and in non-Black. The second subgroup of interest was to compare obese patient versus overweight patient. Obese patients are very often difficult to treat, and this is not only a question of ratio between the dose and the weight, but this is a true resistance. And once again here, no difference in efficacy of firebastat, with a decrease in systolic blood pressure by minus 10.4 in obese patients versus 8.3. Once again, the difference and the p-value for interaction was not significant. So firebastat was as effective in Black and non-Black, and as effective in overweight and obese patients. In terms of safety, the most common related side effects were skin reaction, 4%, and headaches, 3%. We did not observe any angioedema in this 8-week treatment study. Angioedema is a very severe skin reaction, which may happen even if it is rare with ACE inhibitors, and also sometimes with a cross-reactivity with ARBs. This was not the case, despite a high number of Black patients enrolled into the trial. Angioedema is more common in Black. Only one serious related adverse event was reported. It was an erythema multiforme. Otherwise, firebastat was well tolerated. I don't want to go through the lab test because this is very, let me say, very technical, but no change in potassium blood level. And this is important because diuretic decrease potassium blood level, and the ACE inhibitors may increase potassium blood level. So here, no change. It means that from this point of view, this is safe to combine firibastat with other antihypertensive drugs. No change in sodium blood level. This is not necessarily very important in hypertension, but this is key in heart failure, where sodium blood level is very often low. No significant change in glucose blood pressure, but remember that 14% of patients receive a combined treatment with hydrochlorothiazide, and diuretics increase blood glucose. Very important, no change in the renal function, and no concern with liver enzyme. So in conclusion, firibastat, and 85% of the patients receive firibastat as a monotherapy, significantly decrease systolic aortic blood pressure by 9.7 in a diverse population, including 38% of Black patients, high-risk population, 65% of obese, 30% of diabetic. And this is very difficult to compare the result of the New Hope trial with different with other drugs in different trials. First of all, because this is not a head-to-head comparison, and also, as mentioned by Dr. Ferdinand, usually in clinical trial and especially in early development, patients enrolled into the trial are not so high risk, difficult to treat populations. Anyway, one of the last study published, including an arm with valsartan, one of the drugs that has been recalled, with a high dose of valsartan, the reduction in systolic blood pressure was 5.2 after 8 weeks treatment. Also, this is very important to see that firibastat had the same efficacy in Black and non-Black, because in Black, both in the ESC guideline and in the American guidelines, ACE inhibitors and ARBs are not recommended as first-line therapy. And this has been shown in the Whole Heart trial, which was a huge trial conducted in the US to compare the different classes of hypertensive drugs in Black and non-Black. And you've got here the result of the decrease in systolic blood pressure after 1 year, not 8 weeks, but 1 year treatment in Whole Heart, and put in perspective in red with the decrease observed in the New Hope trial. As you can see, lisinopril, ACE inhibitors, is really poorly effective in Black, minus 2.5, and is doing better in non-Black, 8.1. And clortalidone, a diuretic, was the best drug in Black, with a decrease in systolic blood pressure by 7.7 in Black and 9.8 in non-Black. With firibastat, we got similar efficacy in Black and non-Black, with a similar decrease in systolic blood pressure. So the New Hope result in this high-risk diverse population where monotherapy with ACE inhibitors or ARBs may be less effective supports the quantum genomic strategy to further investigate firibastat, which is the first brain aminopeptidase A inhibitor, a new class of treatment in subjects with difficult to treat or with resistant hypertension. It leads me to the next step for us. We are committed to conduct a phase 3 in resistant hypertension. Of course, the design has to be discussed and is currently discussed with our steering committee. And we will work together with the FDA, and we are seeking a scientific advice with the FDA ahead of the standard end of phase 2 meeting. We do expect the study to start by the second quarter of next year, 2019, in order to get the result in 2022. In parallel, we also develop a once-a-day formulation, and especially for hypertension, because most or nearly all the antihypertensive drugs in hypertension are as a once-a-day formulation. And we also go on with our development in heart failure. And the first patient in our quorum study is expected by the beginning of next year, as said by Jean-Philippe. The quorum study is a study comparing firibastat versus ramipril, so head-to-head comparison with ACE inhibitors in patients following first acute anterior myocardial infarction.